All right, Chapter 9, Patient Assessment. It's at this point where now chapters 1 through 8, we've kind of learned all of the skills that we need. This is the last skill to begin treating patients. We've learned skills on what to do with individual things with like airway and CPR and where things are. But now we're going to get deep into what to do in the event. You need to know that you probably are going to be the first ones trained to be on scene with these patients, whether it's trauma or medical. And there is a specific way of doing things, right? It's called a patient assessment. And there are several different pieces of the assessment. These are the 5 assessment pieces that you need to know. Now, there are more, but this is what you need to know for your job. And then as you go on to other things, then they'll add more components to this. Perform a scene size up, perform a primary assessment, obtain some medical history or history of what's going on, perform a secondary assessment to include vital signs, and then if you're on scene long enough, you may even perform a reassessment. We're going to be doing this piece by piece, right? It's an we want to be able to assess the patient to be able to treat the patient. We have to be very careful and thorough and kind to these patients so that we can find out what's going on. Because the minute you're snotty, you may not get everything you want to know. And then you look like a dope when ambulance shows up. So let's start. The sequence starts with a scene size up, right? We need to know what we're doing as we come on scene, right? We talked about this just a second ago. Then I have to do a primary assessment, get the patient's history, perform a secondary assessment, meaning, what else is going on and what has gone on. And then I have to finish up that reassessment if available, if time goes on. So my general overview begins my scene size up, right? I begin my scene size up with driving up. So as I drive up to wherever I'm at, what am I thinking, right? First off, I'm going to think about what dispatch told me. Did they give me a location? Have I been there before? Do I know what's going on in that general area of my coverage area? What did dispatch say the problem was, or type of incident? Was it trauma or medical? Because then I start thinking about different things I'm going to need when I get there. Rather than getting there and looking and then start thinking, I start pre-planning, as it were, on the way in. Did dispatch tell me how many people there were? Or as I arrive on scene, how many people does it appear that I have there? Are they bystanders? Are they patients? And then, of course, also with that scene size up, does my scene appear to be safe as I roll on? And that includes hazardous materials. That includes personnel already there or coming there, or bystanders or other patients and so forth. What does it look like? Now, also with that, what time of day, right? Is it morning? Is it afternoon? Is it late evening? Is it in the middle of the night? What's going on? What day of the week it is going to help me understand too. Tuesday, Wednesday night, probably not going to have your intoxicated individuals. Friday and Saturday night, and you have an unknown crash, it's probably going to be because they have a snoot fault, right? Weather conditions. Is it icy outside? Is it rainy outside? Is it dry outside? Right? We can begin to mentally prepare ourselves for what we're going to see. And we can also call in those things if we're driving by as well. Right? When you come on scene, you need to ensure your scene is safe. Now, I'm going to use my vehicle as my blocker. If someone's going to hit me, I want them to hit my vehicle first. Right? I don't really want to block traffic, but I don't want to be unprotected. So if I have to block traffic, I'm going to block traffic. But if it's way off the road, there's no reason to slow down traffic, especially in the highways. Make sense? It depends on where you're located. Um, Scan the scene as you're parking. How big is it? How many people? Are there additional hazards? Broken metal, ditches, lakes, ponds, alligators, space invaders, you name it. We want to look at all of the possible things. Do I have a crash scene or do I have a crime scene? Maybe it's both. Are there electrical wires or broken telephone poles, power poles, right? Do I have to deal with continuing traffic? Is there spilled fluids, including gasoline? How's the buildings in the area? Are they stable, unstable? What's the weather look like? Are there other people around? Yada, yada, yada. Now, if I'm talking about, so these were the visible ones, the things I can see. These ones may be the invisible. Now, there might be a power line down, but I can get shocked without being right, without touching the power cord, the power lines. So I got to make sure that I'm safe that way. Do I have any biological hazards? And that is including, like wildlife, or maybe this is a farm that was just sprayed with chemicals or sprayed with poop. Do I have any of that going on? The chemical thing, are there hazardous materials going on? And if so, are they on fire causing poisonous fumes? Now, if it's unsafe, you need to keep people away until the specialty team shows up and takes care of things. Right? We don't allow civilians just to go running into the danger, because that's just going to create more problems for us. Now, when we say MOI or NOI, what's the mechanism of injury? What's the nature of illness? Right? What physically caused it, or why are they sick? Right? And we might see clues. Maybe we see a dead deer. Why is there a dead deer there? Because it jumped out in front of the car and caused them to crash. And maybe they were throwing up, and that's what caused them to crash. And we see signs of them vomiting in the car or whatever else. If we don't know what's going on, if the patient can't tell you, I would definitely ask family members or bystanders or whoever, hey, what's going on? Did you see anything? And as you're assessing the patient, don't rule out anything without first doing what we call a secondary assessment, which is looking over the patient head to toe, right? You should always take standard precautions. At the minimum, gloves on and mask available. Minimum expectation. I might need my hard hat. I might need my turnout coat. I might need my heavier gloves because it's so cold outside. But whatever you do, make sure that you wash your hands thoroughly after contact with the patient or contaminated materials. Last thing on the scene size up. How many patients? And if I have more than I can handle, I need to call for additional assistance. And you might have to start triage. Now, triage is a French word that means to sort. What am I sorting? The ones that need the help right this second, the ones that need help but they can wait a minute, and the ones that don't really need my help. Right? Other resources might include law enforcement, fire departments. You might need utility workers or wrecker operators. Maybe you need some more, but rather than the one ambulance that's coming to you, maybe you need 3 or 4 more ambulances. Maybe you need air care. You don't know, but the point is you need to be thinking about these things as you're rolling up. So now you get on scene, and our reason for being there is to identify and treat life threats to our patient. Okay, you walk up, hi, my name is paramedic Robert, said I'm with here with the Tech Center Rescue and EMS. Can I help you today? I've just asked for permission. That's called consent. During this next response, we begin to form our patient assessment or general impression. Is it male? Is it male or female? How old do we think they are? Is it, do they have owies and boo-boos, or do they have ickies and other things, right? Is this a trauma or medical? Are they with me? Are they not? If they just kind of stare off into space when I introduce them, well then, it's a different thing than someone saying, please help me, I don't feel very good, or I hurt all over the place. So we start with a patient assessment. It starts with the general impression. Sick, not sick, hurt, not hurt. What's your gut reaction there? Based on this picture, she's got a grimace going on. She's holding her belly. Sick, not sick, hurt, not hurt. I'm thinking that she's not feeling very good. So right now, kind of clutching over, looks like she wants to go to the hospital even. She doesn't feel good. You establish yourself and you say, hi, I'm so-and-so. And we do that so that people realize and recognize you're there to help. It also helps us to evaluate their level of consciousness. If they kind of just look at you and shrug their shoulders, was that an acknowledgement, or was that they were trying to talk and they couldn't figure out what words to say? Make sure that you introduce yourself even if the patient appears to be unconscious, because they might just be closing their eyes and sleeping while they're talking or whatever. Or while they're waiting, I should say. If I was going to write a note, it would be right here. When I'm assessing the level of responsiveness, I'm going to use the AVPU scale. AVPU scale. Alert. Is the person awake? Now, if they are, we have to define, is it person, place, time, and event? Right? Are they AO4, awake, alert, oriented to person, place, time, and event? So if they're if they're awake, alert, I need to know how awake, alert are they? Times 1, times 2, times 3, times 4. Verbal means I yell at them, hey, are you all right? And they kind of flinch, but then they go back to a state of non-compliance or non-listening. Painful response is they don't respond when I say, hey, are you all right? But I take my fingers, make a fist, and knuckle down to their sternum. It's called a sternum rub. If they don't move with that, they're not going to move. But most times, if they're semi-conscious, they'll kind of flinch, and that's called a pain response. And if you don't respond to anything, you're said to be unconscious, unresponsive. Well, so what do? Very simply, we do ABCs. A quick head to toe. ABCs and a quick head to toe. Number one, I'm going to identify any life threats. Anything that's going to kill them dead, I'm going to fix it. And if there's a cardiac arrest, I'm going to do a cab maneuver, right? I'm going to do circulation first. Otherwise, I'm going to do ABCs. I'm going to sing my ABCs while I'm doing my thing. The A stands for, hey, is your airway open? Now, how would I know that? Well, if they're talking to me, that means their airway's open and they're breathing fine, because zombies don't breathe. Zombies don't talk. However, if the patient's unconscious, I might have to do some interventions by opening the airway. You know, I'm looking for foreign body airway obstructions. I'm looking for secretions. And if I do find those things, I'm going to have to clear that airway. And that might mean suction, but it might also mean I need to put an OPA or an NPA in place to maintain that airway, especially if I move on to other things, which I should. Because now I'm on to breathing. I've got to assess the rate, how fast. Is it deep? Is it shallow? Is it regular? Is it irregular? And if the patient's unconscious, I can look at it and listen to them as I'm approaching in, right? I'm checking for foreign objects and removing them if I find that there's a problem. If the patient's not breathing and they have the airway open, it's time to breathe for them. Does that make sense? And then last but not least, we need to do a circulation check. Now, if the patient's unconscious, we probably should have already been there, right? because we talked about that in chapter 8, where if they are unconscious, unresponsive, I need to check for a pulse. But I'm going to check in the carotid. If the patient is unconscious, I'm going to check in the neck at the carotid. Because if I don't have a pulse there, I have a pulse nowhere. But if the patient is looking around, his eyes are open or her eyes are open, then I'm going to check at the radial pulse for the adult and the child. I'll go for the brachial in all instances for the infant. If there's any major bleeds, I need to fix it, and I need to check for skin color, temperature, moisture of the patient. You know, are they sweaty? Are they dry? Are they cool? Are they warm? Are they pale? Or are they pink? You know, those are what we're looking for. So I see the carotid being used in the left picture. Well, that means he's unconscious, unresponsive. Remember, you're checking on your side. This person's doing it perfectly. And then I'm taking the radial pulse if the patient is, in fact, conscious. Now, as I'm going through here, I'm looking for, what kind of skin color do I have? A pale color indicates, or a white color indicates, I don't have good circulation to that area, right? I'm not even getting blood to that area for whatever reason. Either it's shunting away, or it's bleeding out, or whatever else. A red color, a flush color, indicates maybe I've got too much circulation to that part of the body, or I'm too hot, or so forth. Blue is the cyanosis that we've talked about before. This is a lack of oxygen, and if that's a problem, then I'm going to have to look for the respiratory issues, because if that's the case, I'm not long away from them stopping their heart rate as well. Now, yellow is also called jaundice, and that is indicating liver problems. I see somebody with a yellow tint to their skin, or their sclera, the whites of their eyes. I want to make sure I've got an N95 on my face, because I don't want to pick up anything airborne or bloodborne from them, right? Then, of course, you have normal, which pink, warm, and dry is what we call. And remember, everybody is pink in the same places, the mucous membranes, palms of the hand, right? The soles of the feet. As you finish up your primary assessment and you're getting your vital signs going on, you're going to update responding EMS units. Hey, this is who I have, this is what's going on, and this is the state of their airway, breathing, circulation. We're in the process of vitals right now. We want to give them a really quick update. We don't need it. We don't want to talk on the radio for long periods of time, because quite frankly, we're going to be doing this on open frequencies, and no one really wants to listen to that if they're not directly involved in their assessment, right? So we've had scene size up, we have the primary assessment. Now we're moving on to history taking, and this is where we get into our sample history and our vital signs, and we're going to get all this stuff kind of taken care of. Now, a conscious patient may distract you from trying to figure out what's going on, because they'll want to talk about their grandkids or their dog, or would you like a cookie or something like that. But we need to understand we're there for an emergency purpose. We need to get as much information about the issue that's going on so as to translate it to the next crew, so we can get our patients cared for in a very good manner, and we get our units back in service. So, what does that mean? Signs and symptoms, allergies, medications, past pertinent history, last oral intake events leading up to. Sample history, right? What seems to be going on with you today? Signs and symptoms. If it's a sign, it's something I can see, hear, feel, smell, taste. If it's a symptom, it's something the patient has to tell me. A is for allergies. Do you have any allergies that will kill you dead? Not I have hay fever. Not I'm allergic to dust or cat dander. But I have a peanut allergy or a shellfish allergy that if ingested, I will die. Right? That's the allergies we're talking about. Or maybe medicines will kill you. Medicines. Do you have any medications that you take every single day? Prescribed or OTC, over the counter, OTC. Maybe you take natural supplements. Maybe you're your own, shaman or whatever else. You have all your home remedies. Do you take anything every single day for any medical malady? Because it does matter. Then, past pertinent medical history. P is for past pertinent medical history. What has gone on with you beforehand, and does it relate to what's going on now, right? What things are going on in your life? If I'm complaining of chest pains, difficulty breathing, have you had that before? If so, how does it rate? And blah, 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 right? Last oral intake. What did you eat last? What did you drink last? Maybe that gives us a clue as to what's going on with them. And then E stands for events leading up to, meaning what were you doing right before the present situation occurred? We have to have everything, however you take your history, however you do this, it needs to be in a logical order, right? And we talked about all of these things that we would ask as far as how this goes. And again, the sample history is your framework. Please don't do signs and symptoms. What does that mean? Well, what's your signs and symptoms? Well, what's a symptom? Well, a sign is something I see, hear, feel, smell, taste. A symptom is something the patient tells me, right? I don't feel good. That's a symptom. I throw up. That's a sign, right? When you're talking, you should use open-ended questions, and you use it at one question at a time, and you listen to hear, not listen to respond. You're listening. So, hey, tell me about your current day, right? And they start to answer you, and you interrupt them with another question. And they start to answer you, and you interrupt them with another question. You're not really listening. You're going through your checklist, if you will. Right? When you're listening, make good eye contact with them. Don't stare them down. And if the person is unconscious or maybe senile, maybe a family member can help answer some of these questions. Whatever you do, make sure you write it down so you can give EMS, incoming EMS, update information either on the radio if there's a long response time or as they get on scene. Whenever the ambulance shows up at me as a QR, I say, I'm going to go out and just brief them real quick on what's going on. I give them everything they need to know, a 30-second, we call them elevator talks, 30 seconds of everything you need to know about this patient and why, and then I just assist them the rest of the time. Okay. So here is a great little thing about sample. If I was going to take a picture of something and maybe even print this off from my own home so I could laminate and put it in my pocket, maybe this would be it, so that I could remember what sample stands for. And obviously during the sample history, if you're not doing it, then one of your partners are, you're taking vital signs as well. Okay, so let's assume for a minute that there is no life threats. Nothing as bad is going on with them. They just don't feel good. Or maybe they've been involved in an accident or whatever. But the point is, there's nothing that's going to kill them dead. Their ABCs are intact, and they're AO4. They're A on the ABPU scale, and then they're AO4 because they're awake, right? So then I need to have some more investigation going. We need to talk more about your signs and symptoms, right? We've already talked about a sign being something that the patient, you can see or feel yourself, and then the symptom being something the patient tells you. But what am I looking for, right? Well, for that, we go to DCAT BTLS, right? Now, there's a smaller one that you use, DOTS, deformities, open injuries, tenderness, and swelling, but DCAT BTLS is one of those main acronyms that is used across the board in all levels of EMS. Deformity stands for, do I see anything that is out of whack? It doesn't look anatomically correct, right? Contusions, which are bruises. Do I see bruising, new bruising on this patient? Do I see old bruising? Because maybe I have an abuse situation going on. Abrasions, that would be, your skid marks. Punctures or penetrations, are there any holes in them that there shouldn't be, right? B stands for burns, first, second, or third degree burns. T is for tenderness. If you don't see anything but you touch that area and it hurts, that's tender, right? Lacerations are cuts. They could be smooth or jagged, but it's a rip or a tear or a cut. That's a laceration. And then, of course, we have swelling. Is there anything that is out of proportion? It looks like it's all inside. Now, that can be done whether the patient is conscious or unconscious. The secondary assessment doesn't require there to be a consciousness going on there. Now, if I'm doing a sample history, obviously some of that's going to have to be consciousness type of thing. But DCAT, BTLS, they don't have to be conscious for me to do that at all. And quite honestly, we need to assume that all unconscious injured patients are severely hurt. Okay, and we need to assume that we need to take C-spine and stabilize all of that during the entirety of our exams. Right? Look at your skill drills for that. If I find something, whether it be on a conscious or unconscious patient, well, then I'm going to assess that further. I'm going to get down front. If I find bleeding, I'm going to look at that area. I'm going to cut the pant leg off. I'm going to cut the shirt off so that I can find the problem and fix the problem. We need to pay attention to the ABCs, and then we need to examine all the other areas of the body. Now, we already know vital signs. We've talked about this before, but let's give you a quick redo here. For the respirations for breathing pattern, normal respirations is between 12 and 20 a minute. Now, we don't have a full minute to take vital signs. So you need to do math, right? Multiply by 4 if you count your step for 15 seconds, and you'll multiply by 2 if you take the vital sign for 30 seconds. You need to know the rate of the breathing. Is it easy? Is it hard? Is it labored? Right? Is it equal? The pulse. The pulse rate is between 60 and 100 for an adult. Right? Is it fast? Is it slow? Is it easy to feel? Strong? Is it weak? Hard to feel? Now, athletic adults might have a little bit lower resting heart rate, so be careful not to go, oh my gosh, it's below 60, let's blah, blah, blah. No, but again, we're taking the carotid pulse in the unconscious patient, radial pulse in the conscious patient, and for an infant, we're going to go to the brachial pulse. Okay? And the smaller the person, the faster the pulse should be. In fact, a better way of assessing the cardiac function in an infant is to do what we call a capillary refill check. You just squeeze their toe or their finger until it goes white and then let it go. And then before you say capillary refill, it should go back to a normal kind of look to it, which is about 2 seconds. And you can do that for all patients, and that's good, but it's most effective for the youngers. Blood pressures. Our normal average is 120/80. So if you get to a hypertensive state, you're talking about something that is higher than normal. 130/90 is an abnormal finding, right? And if I can't hear it by auscultation, then I need to feel it by palpation, right? And if I'm feeling for the blood pressure, I'm only going to get the systolic number, because remember, the systolic pressure is the force exerted against the walls of the artery as the heart contracts, right? And then the diastolic pressure is the force exerted against the walls of the arteries as the heart rests, the relaxation phase. We need to check over skin or look over the eyes, the reactivity and the sizes, because there's some things that are abnormal. If I shine a light into a person's eye, that little black part called the pupil should constrict, should get smaller. Now, in a bright, sunshiny area, that may not be true because you've already got so much light that your pupils are already constricted. However, if I have dilated eyes where I see a lot of black and I expose it to light and it doesn't constrict, well, then I have to make that kind of, hey, that didn't constrict. They're dilated and non-reactive. Also, there is the abnormalness, meaning one's constricted and one is dilated. Most of the time that indicates a closed head injury, and we need to get them to the neurosurgeon ASAP, which means the ambulance has got to get moving. Might also indicate a stroke. Constricted pupils might indicate narcotics, and dilated pupils typically indicate an intoxication of like alcohol or super relaxed state. Again, we're doing our secondary assessment. We're checking over their their AO4, are they still with me mentally speaking? We're going to use the APU scale for that. Now, in the event that I'm there for more than 5, 10, 15 minutes, I may have the need to do a reassessment. Now, on a stable patient meaning they just don't feel good, I haven't found anything with the vital signs, anything found with the sample history or the DCAT BTLS that is showing me that I have a problem here, I'm going to take their vitals every 15 minutes. They're stable. But in the unstable patient, I may need to do my reassessment. Unstable being there's something wrong with any of those things. I'm going to reassess them every 5 minutes. All right, so we got to make sure that we're paying attention to those time frames. That might mean that I'm working quite a bit. What does that mean? I'm going to go back and do everything again. I'm going to check everything again. I want to make sure that there's no stone, as it were, left unturned. Again, stable patient every 15 minutes, unstable every 5 minutes. And I need to make sure that if something's changing, if the vital signs are changing, I'm making note of that so that the incoming transport unit does understand that they were this way at the beginning, they were this way during my reassessment phase, and now this is the way they are now. Now, as you talk about your handoff report in the reassessment phase, as the patient gets ready to leave your care and is being turned over to ambulance service, what they need is age and sex of the patient. The demographic information would be nice. Hey, this is so-and-so, he's this age, this is his date, birth, blah, 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 blah. What's going on with the patient? Give them the chief complaint, level of consciousness, how you found the patient, right? Give them the most current set of vitals. If you did a secondary assessment, what are the results of that? Any reassessment that you did, give them the results of that. Give them pertinent medical conditions using the sample format. And then if you've done anything, like I put them on oxygen, I set them up, I splitted them, I stopped their bleeding, all of those things, those go to what did you do as an intervention. When I say interventions, what did I do for the patient? Okay, that's all in your handoff report. Remember, that's about 30 seconds. You're not going to give them the life history since the time began, right? Now, just a quick word about the difference between medical and trauma patients. Trauma is awe boo-boos. Medical is I feel bad on the inside for the most part. Those who have sudden illness, those are medical. Those who sustain trauma, who are hurt, well, then that's your trauma patients. Now, both medical and trauma patients follow the same kind of format. Okay? Now, obviously, for a medical patient, you probably won't use DCAT BTLS because that's a trauma assessment. And for trauma, maybe you don't get on to sample too much. A little bit, because just need to know allergies and medicines, but past pertinent history at this point, maybe not really relative, right? Make sure you follow your basic patient assessment sequence when you're doing medical. And when you're doing trauma, make sure you're giving a good look from head to toe. Do I see anything for the DCAT BTLS? And please, please, please don't allow distracting injuries to pull you off a task and cause you to jump around. Always do the assessment the same way every time. You do an assessment and somebody else can start the other things. But if you jump around, you will miss something, and then you could stand a chance of hurting the patient. Okay? Well, that's chapter 9. Let's do a quick, I got 4 slides here of the primary things. When we're talking about a patient assessment, as you need to have it for an emergency medical responder, here are the 5 steps. Number 1, scene size up. What's going on with the scene? What's my gut reaction? Right? A primary assessment. I'm doing my ABCs. Are they breathing? Is their airway open? Do they have a circulation going on? Then I'm going to get the patient's medical history, the sample history, whether it be medical or trauma, more relevant in the medical than the trauma. And then I'm going to start my assessment, my physical hands-on assessment. That's more for the trauma than the medical, although there will be some similarities. And then if I need to do a reassessment, then I'll get that done as well. Don't forget the scene size up includes the incident and its surroundings, not just the patient. During the primary assessment, determine and correct any life-threatening conditions. Make sure that in the primary assessment that you are forming a general impression. Are they sick, not sick, hurt, not hurt? On the AVPU scale, how are they doing? Alert, verbal, painful, unconscious, right? Do that rapid scan, and then make sure you're updating incoming EMS units. Now that maybe your protocol is you get on the horn, the radio, and call them, or maybe you just give them a handoff report. Medical history, as we talk about that, gives us a systematic way of relaying a patient's past medical history, their conditions, their illnesses, their injuries, to determine what's going on currently. And then the secondary assessment consists of looking over the body again for non-life-threatening conditions. Scrapes, some owie boo-boos that could use a Band-Aid or some cleaning up that don't necessarily need to happen, but if you have time for it, you can. And finally, please remember that if a patient is stable, they get a set of vitals every 15 minutes. If they're unstable, you need to repeat them every 5 minutes. 5 minutes. Finally, hand off your report. Be concise, be proper, and then assist EMS, the responding EMS, transport units, in getting your patient into the ambulance and sent away. That is chapter 9.